So I'm going to start with the presentation on coronary bypass graft angiography. Several fellows have asked me about the techniques and the anatomy because it's a little bit different from a usual coronary angiography. The first most important thing is to actually understand the graft anatomy. And the surgeons, they have different ways of putting the grafts, and it's important to know what type of grafts are there. So the most important thing to know is to get the information or the notes, the operative notes to begin with. And if there's a CT scan already available from because of CTPE, or if there's a coronary angiogram CT, those will really help you to find out where the grafts are and if they are patent or not. I personally think that if it's just being done for a stable disease, I think it's a good idea to just do a CT angiogram rather than a coronary angiogram, because you waste much more of a contrast when you are doing a coronary angiogram if the grafts are unknown. The other thing that you need to know is that many surgeons put some form of markers on the aorta. In that case, if there are markers, it's easier to find the grafts, but many surgeons don't put any markers, and so you're just trying to find it in the dark when you're there. But the graft anatomy is important. So just to illustrate, can you see the whiteboard?
Yes.
So in a usual aorta, you have 3 branches. Okay, this is the aortic valve. This is innominate artery. Innominate. And then this is the carotid, LCA, left carotid artery, and left subclavian artery. So when the surgeon opens the chest, this portion of the aorta is exposed. Okay, and they're going to sew the grafts right anterior on the aorta, not posterior. Very rarely they have to sew a posterior graft here. And it's important to know where the SVG grafts are. Usually the RCA graft will be here, more on the right side or on the left side of the screen. And then the LAD graft is usually on the lower side. It could be here, somewhere here. And the circumflex or OM grafts are usually high here. Okay, somewhere here in this line. So when we are looking at the grafts, we are kind of searching in this territory. There's RCA coming out here, and there's left vein coming out here. Okay. The RCA graft would either go, most of the time it goes down like this. So it has an inferior takeoff, but it can have something like this as well, like that takeoff. The LAD, because the LAD is somewhere here, RCA is somewhere here, and then circumflex is somewhere in the back. So LAD comes, or diagonal graft, if there's a diagonal, is coming right and straight like this. The circ, on the other hand, takes a longer path and goes to the back of the heart. And usually, so if this is the heart, I'm just making this heart up. So you might need different type of catheters depending on where these different things are. Now, if you're coming with through the RCA, this portion of the heart is difficult to access. So if there's a graft on this side, you need a very long um, secondary curve to access this. This is easier, this is easier, and then this is easier. From the left side, it's much easier. You see, you can have a catheter down here. This becomes a little bit more difficult, but you can get these grafts very easily down here and down here. Femoral is also easier because you can get this. So make sure if there's a graft here, you should know about it. And you do use different type of catheters for that. Any questions about this?
No.
Okay. So these are the SVG grafts. Usually you can have a free radial graft. Free radial graft means that the radial artery is cut in two sections and then is taken off and then put on somewhere here. Free rema means the rema is coming out of here, rema from the subclavian, not the innominate, and you cut down here and put it down here. So sometimes it's written as free rema. That means it's not attached to the vessel up here. But if it is inside to rema or like it's attached, then you have to search something here. So the right radial artery access will be great. Femoral access is great for those. Same thing with lima. You will have lima coming out of here from the subclavian just across the thoracoacromial junction. But sometimes the lima can be coming from the vertebral artery, and that can be a problem. You have to access it. Or it could be coming from the thoracoacromial duct. But it's usually in this segment, somewhere in the 1/3, the top 1/3 of the subclavian artery, where it's giving the vertebral artery just close to that. And it's coming off the anterior wall. So you have to get anterior wall. So the best way to get is LAO 30 to 40 degrees for the lima and look at it. Because what happens in 30 to 40? The aorta will become something like this. You can see the whole aorta, and you can see the vessels coming out of the aorta like this in the LAO. Okay. So otherwise, in an AP view, you're seeing the aorta something like this. Okay. AP. So it's difficult. Sometimes they are overlapping like this, arteries. So it's difficult to get it. So I prefer LAO 30 to 40 degrees for the lima. Okay. For the rema, it's easier to get through the right radial, as I said, or you can use the same way from the femoral artery. You can get it from the left side as well with some advanced techniques, but it's preferable in the beginning probably not to use those extra cool techniques to get it. What else? That's pretty much it about the graft anatomy. The next thing would be about different forms of grafts. So the graft can be stored in different ways. So I talked about the right radial axis, left radial axis, and femoral axis. So in experienced people, in their hands, even lima can be accessed from the right radial. The left radial is what we usually use because we are a radial institution now. But the femoral access, I mean, there's no harm in going through the femorals in these patients. If you're gonna really muck around the catheter, just go through the femoral, or if the grafts are unknown to begin with. Um, I usually do left radial, right radial. I really rarely go through the femorals, but if needed, you can go through the femorals. Catheters that we use. we use are these catheters. So this is, oh, wait a second. So this is Tiger catheter or TIG catheter. And some people say they can just use TIG catheter from the left radial and use this for all the grafts. And it can be done. This is JR4 catheter. Okay. This is the GL35 or GL4 catheter. GL35. This is the right coronary bypass catheter. And this is left coronary bypass catheter. And then this is called BC catheter. Okay. So these are usually the catheters used for accessing the coronary bypass, especially the SVGs. There are other catheters, and I myself use a lot of the Amplats group of catheters. Amplats look something like this. Those catheters, depending on how far the coronary or the graft ostium is, you can switch the sizes. So AL1, AR1, AR2, AL2, AL3. These are other catheters you can use for this. Rarely, I use hockey stick catheter as well. And the hockey stick is something like this, close to EBU catheter. But usually if you go through this series, you will get most of the grafts without having any problem. As I said, Tiger catheter can be used for all of them. In a usual 60 or 65 years old guy who had bypass. But sometimes the aorta is small in size, so it becomes difficult to get those. The other thing that I wanted to go over is these composite grafts. So, it's difficult to understand sometimes the graft anatomy. So that's why I said in the beginning, you really need to go through the operative note. We recently had a case and in which everywhere in the notes it was mentioned patient has 2 grafts. Looks like this, CABG times 2, okay? But it was just 1 graft with some of the modification of this. So it was a sequential graft where there was a graft coming down from the aorta. So this is aorta. And I'm gonna make and there was ours here like this. And this graft, when it comes down, it touched this PL branch. And then on the other side, there's OM. And then it was touching the OM graft. So there was a sequential graft here. And they called it CABG times 2, but it's actually just 1 graft. We spent 45 minutes to look for another hole here. We couldn't find that because there wasn't one. And at that time, we looked back and finally found the report because we did not have the report at the time of doing this. Once we got the report, and sometimes, your assistant can help with getting the report. So it's very important to get the report. The other thing I said that if there's a CT scan done, look at that CT scan where the graft is coming out of. Anyway, wanted to go over these grafts, different grafts. So what is a Y graft? So Y graft is an older technique, the classical Y graft, which that means is you put a graft like this. Or it's all called, sometimes called T graft or Y graft. Okay. And there are 2 vessels. So I'm going to make the coronary vessel so that it's attached to the 2 vessels. And the main reason is because if the graft is large in size, the vein is large, and this vessel is small, you don't want to have this graft to close, because SVG close up if the outflow is bad, and Lima goes up if inflow is bad or inflow is high. So like if you have a lot of flow coming into the LAD, the Lima would get acritic in those cases. So and it's not a definitive thing, but usually that's what we see. If the inflow is bad, even in the SVG would also close up, um, but that's why they want to have a good outflow. Okay. So then the next type of graft is, I had pie graft. Might not have seen this one, but this is attached to the main vessel here, and then you have two extra grafts coming out like this. So it looks like a pie. Okay, and so like it's like Lima coming here. This is Lima, and then you have two grafts attached to a diag and a OM, something like this. Then there's another graft which is kind of a Y sequential graft, where the Lima, if it's coming like this, let's say, to the vessel, and there is graft is coming like this, and then from this graft, there is another graft. So there's a vessel here, there's a vessel here, like OMs. Usually it happens to the OMs. And you can keep on having sequences in here. It's sometimes called new Y graft or Y sequential graft. Sequential graft. And it depends on the surgeon how he looks at it. He can call it a T graft as well. The next graft is K graft. K graft is something like this with something like this. Sorry. So if the vessel is like this, and another vessel is like here, you can have Lima, and then just giving it could be any SVG as well. And then you have something like this, K graft. And sometimes this limb could be closed, and you'll see a weird kind of picture on the scan that there is a graft going. So if you don't know the report, you will not know if this limb is already gone. So always look up on the angiogram if some territory is missing. The next, so this is called K graft. Next graft is I talked about sequential. You can have other modifications, double Y graft or Y double sequential grafts as well. So either there's a Y graft like this, and then sequence after this on the vessels. These are the vessels. These are the vessels. Or you can have something like this. So these are the vessels, and you have one, and then you have one more, then you one. So these like a Y sequence. So there's another Y, and then another Y. It's not end to end. So you have to see if it's an end to end or side to end kind of graft. So this is important to know these anatomies. Just wanted to go over these different type of names that you might see. Anyway, so going back, do you have any questions? Any questions, guys?
No.
No questions. Okay. So what could be the reasons for not seeing any graft? And it's a Google picture um, uh, that you can find. But mainly what you can see is that either there's no stump or there's a stump occlusion. So right on the aorta is gone, or it's an unusual graft. What could be an unusual graft? This type of graft could be unusual where you have right gastroepiploic artery attached to a right PDA or OM. Okay. So what they do is the surgeon takes this off and attaches there. And to get it into this artery here, celiac trunk, you sometimes might have to use some specific visceral artery um, catheters like Cobra catheter, or you can talk to your interventional radiology colleagues that how to take care of it. But you wouldn't know it if you don't have the operative report. But this is something that always have to keep in your mind. Uh, let's see what else I have on this topic. So yeah, so this is like that. So you can see this is the gastroepiploic artery attached to the somewhere here to the PDA, as you can see. So the needs to be engaged from the bottom. So the other thing is this that so we use this catheter here called Bertorelli-Causi catheter, great catheter, um, but it's also very sharp catheter. So you see this edge can sometimes damage the lima. So usually we use lima catheters or BC catheters, depending on the whatever the person's comfortability is, but they're mainly for the radial access, not from the femoral access. I saw somebody using the BC catheter from the femoral access. It's dangerous. So it's mainly for radial access. And you can go from even the right side to the left side. And it's a interesting maneuver where you can go with a wire here and then move the catheter upwards. And once you are here, you can just push the wire into the arm and then put a blood pressure cuff on the arm and inflate it, or make the person really make, flex his elbow. So this wire is stuck here. Once it's stuck, you have a rail, you can just push it up and just lock it and just make it look anterior and you can access it. The other thing, yeah, I totally forgot about that part is that how to actually engage the bypass grafts. Okay. All right. So usually I start with the right-sided grafts. Let me do my drawing again. So this is the innominate left coronary subclavian. And then this is the aorta. Okay. So right is coming out here, left is coming out here. And then you're looking for the grafts on the anterior aspect somewhere here. And I told you about the different, this is how I'm looking at it in a sequence. To access this graft, I use the same GR4 catheter, okay? Now, sometimes this might be a little bit dilated, this diameter might be dilated. So you can then use GR 4.5 or AR1 catheters at that time. But what you're doing is, as soon as you disengage from here, you're kind of pulling back and moving it counterclockwise, clockwise, counterclockwise, clockwise, and usually get stuck in here. GR4 catheter is great. It can even get this LAD as well. But if the aorta is dilated, which happens in many of our patients, then GR4 will not be enough. Otherwise, GR4 can get it here. So either you're from, it's better to have from here, uh, and it's like this, right? So you can get it from here, but you will not be able to get these ones sometimes. These, if they are superior OM, uh, OM grafts there. So then you can switch to another form of catheter, but try with GR4 first. Then what the next catheter I usually use is, if I don't get it, I get the left main with the usual JL4 if I'm coming from the right radial, or JL35. You can use Tiger catheter, or some people use Jackie catheter. Once you get the left main, then you can use the same catheter to look up these again. Okay. For the for the RCA graft, if it's coming inferior like this, other options would be MPA catheter, MPA2, and I prefer to use a smaller, like a 5 French catheter, rather than a 6 French catheter for these, because it's easier to manipulate. The other thing that I like to use, which we do not have, is the Glide MPA, or multi-purpose catheter. Glide multi-purpose is really nice to do use. And what I do is I put it in the RCA cusp and prolapse it, look like this. Once it looks like this, I then bring it back, clocking and counterclocking, keeping this tip of the catheter towards the anterior aspect. And for the RCA, I like to do it in the LAO or in AP view, because what happens in LAO and AP view, it looks like RCA. It's coming out of from here, from the left aspect of the screen, or the aorta. Let me clear that all again. Making it red. So, any questions about this? You see, there's intervention fellows here now. So this was about this side, the RCA. Engagement. For the left side, so let's say the GR4 didn't work. Actually, so then I use MPA catheter. If that doesn't work, then I use right coronary bypass catheter, or AR1 or 2. So if there's an inferior takeoff, MPA catheter, they both work with uh, inferior takeoff as well as horizontal as well as superior. But if it is a superior takeoff, then you have to make this curve, I told this curve, larger, so like this. And for that, you need to use the AL1 or AR2, then AL2, AL3, okay? So you have to make it large. So, but you'll get one of these if it's somewhere around here. This this takeoff of SVG from here. For the left-sided grafts, I prefer to use RAO. And the reason I use RAO is that on the RAO, the aorta will turn and you can see the grafts coming out from the right aspect of the screen, or the left side, because they're coming from the anterior aspect, right? So you can see them coming out of this side, and you can just slowly go up. Usually there's a left main coming here, and then you use the left main and go up on the same line, and you will get the LAD, And then OM is just, or circumflex graft is just right above it or just next to it. Okay, so then you use that. So I use I use the JLs first. Then if it doesn't work, Tiger is great. That doesn't work, then I start going to the ALs. AL group, AL 1, 2, depending on what the size of the aorta is. If the catheter keeps on looking down, I know the AL is large. If the catheter keeps on looking upwards like this, and it's not touching or not getting stuck with the aorta, that means it's undersized. Then I have to go in this direction, 2, 3, 4. If it's continuously looking down and I'm not able to make it prolapse upwards, then I have to go in this direction. And then if they don't work, then I start getting hockey stick, something with a um, long curve, or EBU, hockey stick 2, hockey stick 1, EBU, JCL. JCL works. And in this direction, I keep on moving to get that side. But RAO is what I prefer. If RAO doesn't work, we can go LAO to look at where it is, or AP. RAO tells you that it's in the anterior wall, so you keep the catheter always pointing towards anterior side, not to the posterior. Rarely people can have have a graft posteriorly attached, and it goes through the transverse sinus between the PA. There's a PA here, right? It goes through that and attached to the circumflex in the back, somewhere here, like this. All right, so that was pretty much it about the graft anatomy and how I access them um, and use catheters, how to access them. All right, any questions that you guys have?
Dr. Qureshi, do you have cases of these grafts?
We can look them up in a second. Last thing, I just wanted to tell you something historic before we finish. So this is heart, right? My heart. Aorta is coming out like this. When the surgeon opens the heart, um, the RCA is coming somewhere, it goes into the groove, and then it comes back, it gives the PDA. And it's coming anteriorly, actually. People think it's on the other side, like on the angiogram, if they don't really look at the heart. The left main is also coming anteriorly. And they're just looking, imagine you're looking through the sternum, okay? And then circ goes like this, so it's circumflex, right? And then LAD is coming right in the front, like this. So when they first saw the diags, so they were going like this. So they were diagonal arteries. When they lifted this heart up, you lift the heart up, you can see the base now. Base is like this, okay? With the PDA coming in the middle, and then you have a circumflex coming on this direction with marginals. So they called them marginals, and they had, the angle was obtuse, so they called them marginals, and they're coming somewhere behind. So, and there was another marginal coming from the RCA like this, and they called them acute marginals. So just a historic background that how they name. So sometimes what happens is that the PDA or the marginals are so close, and it's a left PL branch, they might say they attach it to the OM or to the PDA, but it's not really a PDA. Or sometimes they can write in the operative note that there's a PL branch rather than a PDA branch. So take the report with the salt of grain whenever you're reading the report. Um, it might not be 100% accurate. And sometimes, with these electronic health record systems, you're dictating and you're doing like 4 or 5 cabbages that day. It might be that you might say some vessel, but it's not the vessel that you actually find. So, but most surgeons are pretty good about it. They are very diligent in writing their reports, and they're usually right. Uh, but it has happened to me a couple or maybe 3 or 4 times that the grafts were different than what it was mentioned. Okay, I'm going to stop this recording.